Hello, our latest podcast is from the British Cardiac Society in London at the Excel, joined with our clinical champion for cardiology, Sadian, who is joined with Dr Lynne Millar, a cardiology registrar in London, and she's presenting a poster. Welcome, Sadia.
Thank you very much, Billingsley. We're at British Cardiac Society today, and I've got Dr Lynne Millar with me today, who's going to talk to us about her poster she's presenting this afternoon. I'm just going to hand over you directly to Lynne.
Hello there. I am presenting a poster on a project that we performed at St George's Hospital in Tooting in London. This was on the back of the chest pain of recent onset CG95 NICE guidance that was produced in March of 2010. One of the novel aspects of this guidance was the use of CT coronary angiograms in the management of patients with chest pain of recent onset. And I'm just going to run through our experience that we saw in the rapid access chest pain clinic over a 32-month period. Just to run through in summary of what was involved with what NICE suggested is NICE gives some criteria to how one would stratify typical angina, and they give certain criteria to stratify patients into sort of typical, atypical and non-anginal chest pain. And based upon their age, the character of the chest pain and the sex, patients are given a pre-test probability of the likelihood of having coronary artery disease. And based upon this, they are stratified as to what would be the most appropriate outpatient investigation. Those with a pre-test probability of 10 to 29%, NICE suggests that you go ahead and do a calcium score, and you may go ahead and do a CT coronary angiogram at the same time. So we looked at our patients in a 32-month period spanning from April 2009 to December 2012. The default position at our centre was to use CT coronary angiogram and CT calcium score at the same time. And during this time we had the use of 64 multi-slice scanners and also newer generation 128 multi-slice CT scanners that were capable of flash acquisition and prospective gating. We looked at the radiation dose that was calculated from the dose response product that was reported on the CT scan to assess what radiation the patients were exposed to. Overall, in this period, we had 168 patients, slightly more females than males, 68 males and 88 females. So looking at our sort of demographics, the overall radiation dose that people were exposed to was in those scanned in the newer and older scanners was 6.38 millisieverts. But there was a marked contrast and lower radiation dose those scanned in the newer scanners with a radiation dose of 3.27 millisieverts. And this was actually, the difference between those scanned in the newer and older scanners was particularly significant. Now, some of the interesting findings from our results, we had 96 patients had a calcium score of 0. Now, going strictly by the NICE criteria, these patients may not have been further investigated. What we found is that 5 of these, when we went on to do a CT scan, which is around about 5.5%, actually had significant coronary artery disease that may not have been picked up otherwise. And 3 of these actually went on to have intervention in terms of either bypass or percutaneous intervention. When we look at our groups with a higher calcium score, calcium score greater than 1, there was a much higher proportion that had significant coronary artery disease, as one would expect. So the other thing that was interesting in this study was looking at those who NICE would have strictly recommended they went straight forward for conventional X-ray angiography. Those are the pre-test probability of having a score greater than 90%, 60 to 90%. By doing a CT scan in these patients, we found that actually 50% had no significant pathology, and which is quite interesting, which saved them having a conventional angiography. And those who had a pre-test probability of 90%, more than 90%, actually that NICE would have suggested to treat as stable angina. So we actually had prognostic disease that required further intervention. So I think in conclusion, I think that a calcium score of 0 in symptomatic patients does not actually rule out significant and prognostic coronary artery disease. And this is actually supported in the literature from other studies that have read. using prospective gating with patients with a controlled heart rate and in sinus rhythm, using newer generation CT scanners, significantly reduces the rate, the exposure to radiation. And actually, given that 50% of our patients recommended when NICE they suggested to have angiography as a first line of investigation, did not actually have disease on CT scan, this may be something that can be used for higher risk patients in the future. One thing of note in our patients is that Inchitting has a very high Asian and Pakistani population, and we find that maybe the demographics that is reflected typically in the NICE guidance is not necessarily always reflected on your own patient cohort. And we find that those who had calcium scores of 0 and those who went on to require actual intervention were usually young females who may not have had calcium deposition as part of their atherosclerotic process. So I think this is one very interesting point from our project.
So thank you very much, Lynne, for speaking to us today, and we wish you good luck with your presentation this afternoon. It does raise some interesting questions about whether the NICE guidance is appropriate, and I think it would be very useful to know what the doc2doc community think, particularly around whether CT calcium scoring should always be followed by CT coronary angiography, and whether NICE cut the guidance too low and that high-risk patients should be considered. We hope you enjoy the rest of the conference.